Imagine waking up every single month with a sponge full of concrete that's just slowly squeezing and crushing inside your abdomen.
Oh, that sounds awful.
Right. You're in excruciating pain, your life is completely on hold, and, well, when you finally get a doctor to look at your test results, they tell you absolutely nothing is wrong. They just say, take some ibuprofen.
Yeah, and sadly, it's a scenario that plays out in clinics all over the world, literally every single day.
Just dismissed entirely.
Completely dismissed. I mean, we desperately want medicine to be this binary thing, right? Broken or not broken, sick or healthy. But when you step into the world of chronic pelvic pain, that illusion of precision just totally shatters.
It really does. So welcome to the deep dive, everyone. Today, our mission is to decode a condition that has lived in those diagnostic muddy waters for decades.
It's been incredibly misunderstood.
Exactly. We are pulling apart a massive 2026 clinical expert series from the journal Obstetrics and Gynecology on a heavily misunderstood yet incredibly common condition called adenomyosis.
And our goal today is to extract exactly what this hidden disease is, why the medical establishment historically they completely missed it, honestly.
It really did.
And we'll get into how cutting-edge imaging and these new uterine-sparing treatments are finally offering patients some actual, tangible validation.
And look, even if you don't have a uterus, you definitely know someone who does. The data we're looking at shows this condition affects up to a third of symptomatic women.
A third. That's a massive portion of the population.
Right. So understanding adenomyosis isn't just about the biology, It's a shortcut for you to be an informed advocate for your partner, your family members, or friends who might be just silently suffering from this unexplained, debilitating chronic pain.
Exactly. It's about pulling back the curtain on something that has been normalized as just quote-unquote bad cramps for far too long.
So let's get right into the anatomy of what's actually happening. Adenomyosis is defined as ectopic endometrium growing within the myometrium.
Right, which sounds like a lot of jargon, but
yeah, for anyone listening who follows reproductive health, you probably know the endometrium is the inner lining, and the myometrium is the thick, muscular wall of the uterus.
correct. And in a healthy organ, there's a really strict border there.
But with this condition, that border is completely breached, right?
Yes. The cells from that inner lining physically invade the dense muscle tissue. And the historical context of how medicine viewed this invasion is, frankly, shocking.
How so?
Well, for the longest time, the medical establishment considered adenomyosis strictly a disease of women over 40 who were multiparous.
Multiparous meaning women who had already carried multiple pregnancies.
Exactly. They thought it only happened to older mothers.
Okay, let's unpack this because I need an analogy here. If the normal uterine lining is like, say, the plants growing in a flower bed, adenomyosis is like finding those exact same plants, these relentless weeds, growing deep inside the actual brickwork of your house.
That is a perfect way to visualize it, yeah.
But if this affects up to a third of symptomatic women across the board, how on earth did the medical community think it was only a disease of 40-plus multiparous women for so long?
It comes down to a massive structural blind spot in how they diagnosed it. For decades, I mean literally decades, the absolute only way to definitively prove a patient had adenomyosis was through pathology.
Wait, meaning they had to test the actual tissue?
Right, and that could only happen after a hysterectomy.
Oh, wow. I see. So you literally had to remove the entire house, smash the bricks apart, and look at the dust under a microscope just to prove the weeds were in there.
Precisely. And so think about who were the patients actually getting hysterectomies back then.
Older women who had already finished having children.
Exactly. It was a completely self-fulfilling diagnostic loop. The data inevitably skewed toward that specific demographic because they were the only ones getting the surgery that proved the disease existed.
Which completely abandoned all the younger patients who were suffering.
Completely abandoned them. And to make matters worse, adenomyosis is rarely just an isolated issue. It often coexists with uterine fibroids, which are also known as leiomyomas.
Right.
And it coexists with endometriosis up to 40% of the time.
So a 25-year-old patient would present with terrible pain. The doctor would find a fibroid, remove it, and just blame the fibroid for everything.
You hit the nail on the head. The true culprit, the adenomyosis hiding inside the muscle wall itself, was completely masked by these other conditions.
That is wild. But how do those cells actually get into the brickwork to begin with? because I was digging into the pathophysiology in this clinical series, and there seem to be two main theories.
There are, yes. The first one is the invagination theory.
Right, which suggests a cycle of mechanical injury and repair.
Yeah.
Let's say someone has a C-section or some sort of uterine surgery. That creates a micro tear at the border, right?
Exactly. It creates a weakness in the wall, allowing the lining cells to just slip in and start growing where they shouldn't.
Okay, so that's the mechanical mechanism. But the other one, the metaplasia theory, that one is even more complex.
It really is. It points to embryological migration, which is fascinating.
It suggests that while a patient was still just a developing fetus in the womb, stem cells got left behind in the wrong part of the uterine wall.
Yes, exactly.
Wait, really? So if the metaplasia theory says this is leftover fetal tissue, are you saying some patients are essentially born with the seeds of adenomyosis already planted in their uterine muscle, just waiting to wake up?
That is exactly what the theory suggests. Those dormant cells just sit there quietly until puberty, when the hormonal cycles finally kick in.
That's terrifying.
And regardless of how those cells get in there in the first place, whether through a surgical tear or fetal remnants, the end result is incredibly destructive.
Because they react to the hormones.
Right. Because these invading cells are endometrial tissue, they respond to the monthly estrogen cycle. They swell up and they bleed.
But the blood has nowhere to go. It's trapped deep inside a rigid muscle.
Which triggers massive cascading inflammation. And the clinical statistics reflecting this are just brutal. Abnormal uterine bleeding happens in 40 to 60% of patients.
Wow.
We're talking prolonged, extremely heavy bleeding, passing large clots. Then there is severe progressive dysmenorrhea, which is intense menstrual pain, in 60 to 80% of cases.
And when doctors do a physical exam, instead of a firm, healthy muscle, they feel what is clinically described in the paper as a symmetrically enlarged, distinctively boggy uterus.
Yes, boggy is the exact medical term they use.
Boggy, like a sponge full of concrete that is still trying to physically squeeze itself. That sounds excruciating.
It truly is.
But wait, if fibroids and endometriosis are often happening at the exact same time in that pelvic cavity, how do doctors even know the pain is specifically radiating from this boggy adenomyotic muscle?
What's fascinating here is what happens at the microscopic level. It's not just the physical bulk of a swollen uterus causing pain. The depth and the total number of these little pockets of trapped bleeding directly correlate with pain severity, and that's because that active, constant inflammation triggers something called neuroangiogenesis.
Neuroangiogenesis. So neuro meaning nerve, and angio meaning blood vessels, so new nerve and blood vessel growth.
Yes, exactly. The disease literally rewires the uterine environment. It sprouts new pain nerve fibers directly into the inflamed, stretching muscle.
Oh my God.
Yeah, so the pain isn't just a normal cramp from a muscle contracting. It is a fundamental structural rewiring of the nervous system within the uterus. It creates this localized environment that is just constantly firing severe pain signals.
So seeing these weeds without taking the whole house apart is crucial. But seeing the problem doesn't actually solve it. How are doctors getting the weeds out of the brickwork today? I mean, we finally moved past just doing a hysterectomy for everything, right?
Yes, thankfully. The technological shift here has been completely revolutionary. We don't have to wait for pathology anymore. Transvaginal ultrasonography and MRI now offer 70 to 80% sensitivity for detecting adenomyosis entirely non-invasively.
The ultrasound criteria really caught my eye in the paper. There's this standardized assessment called MUSA.
The morphological uterus sonographic assessment, yes.
Right. It's basically a 9-feature checklist. Doctors are looking for things like globular-shaped uterus or fan-shaped shadowing on the scan or tiny myometrial cysts. And if they spot 4 or more of these specific features, it strongly predicts the disease.
And if they use MRI instead of ultrasound, they focus on the junctional zone.
That's the crucial border between the inner lining and the muscle, right?
Exactly. In a normal uterus, it's very thin. But in adenomyosis, the MRI often shows it swollen, usually thicker than 12 millimeters.
Okay.
Though, to be accurate, thickness alone isn't enough to diagnose it. The radiologist also needs to see bright cystic foci and linear striations physically pulling down into the muscle.
Now, here's where it gets really interesting to me. We have this 9-point checklist with MUSA. But if a doctor is just looking at a gray, fuzzy ultrasound screen, isn't looking for, like, fan-shaped shadowing or blurring, highly subjective.
It can be, absolutely.
Because if you're listening to this and wondering why your doctor never mentioned MUSA during your last scan, how reliable is this compared to the old-school biopsy?
It's a very valid question, and for a long time, interpreting those shadows was completely dependent on the individual doctor's skill and experience. But that is exactly why the shift to 3D transvaginal ultrasound has changed the game.
Because of the clarity.
Right, yes, there's still a human element, but standardizing the language through MUSA gives doctors globally a shared objective vocabulary.
So they can't just guess anymore.
Exactly. Instead of a doctor just vaguely writing, the uterus looks boggy in a chart, they're forced to tick off specific, validated morphological features on a 3D scan. It allows them to spot that irregular junctional zone long before the disease progresses to that severe concrete sponge stage.
Okay, so we can finally diagnose it early and objectively. Now, let's look into the pharmacological toolbox. How are we actually treating it? Because looking at the data, the drug options seem incredibly well borrowed.
They are. They really are. Because adenomyosis was historically ignored as its own distinct entity, the current medical management is largely extrapolated.
Meaning the treatments are entirely borrowed from the data on fibroids and endometriosis.
100%.
Right. So we start with non-hormonal options. NSAIDs for the inflammation and tranexamic acid. And tranexamic acid isn't a hormone, right? It's an antifibrinolytic.
Correct. It literally stops blood clots from breaking down so quickly, which is how it cuts that massive menstrual blood loss in half.
Wow, by 50%.
At least, yeah. But it targets the bleeding, not the disease itself. Then you move up the ladder to the progestins, the levonorgestrel intrauterine system, which most people know as the Mirena IUD, and oral drugs like Dianogest.
And these show pretty massive symptom relief, don't they?
They do. They work by creating a hyperprogestin environment that physically thins out the uterine lining and suppresses that local inflammatory response around the trapped glands.
Okay, but if the progestins fail, you bring in the heavy hitters. The GnRH agonists and antagonists like relugolix or elugolix.
Right, the big guns.
From what I understand from the study, these essentially block pituitary signals in the brain to create a reversible hypoestrogenic state. It's like a temporary chemical menopause that just starves the disease of estrogen, shrinking the uterus down.
That's a perfect summary. And we're also seeing some fascinating investigational approaches completely outside of standard hormones.
Like what?
Vaginal bromocriptine, which is typically a dopamine agonist used for pituitary tumors, and valproic acid, which is actually an anti-seizure medication.
Wait, an anti-seizure med? That's wild. So using endometriosis drugs for adenomyosis is basically like turning off the main water valve to the house because you can't find the specific leaky pipe.
Yeah, that's fair.
It stops the flood, but it's a massive, blunt instrument. Why aren't there more drugs specifically built from the ground up for adenomyosis?
Well, if we connect this to the bigger picture, it really highlights the historical neglect we talked about earlier.
Because it was a missed disease.
Exactly. Because it was hidden in hysterectomy data for decades, it never received the billion-dollar funding required for highly specific, targeted drug trials.
That is so frustrating.
It is. However, because adenomyosis shares hormonal and inflammatory pathways with endometriosis, they are both fundamentally driven by estrogen and inflammation, the blunt instrument actually works quite well for symptom control.
But relying on borrowed science means we are still treating the symptoms, right? Not the root structural cause of why those cells invaded the muscle in the first place.
Precisely. We're managing it, not curing it.
So the pills are turning off the water valve. But what happens when the pills aren't enough? The pain breaks through, and the patient absolutely refuses a hysterectomy. We get into some seriously sci-fi interventional and surgical options here.
We do, and this is where precision medicine is advancing so rapidly. We're talking about focused heat and uterine-sparing techniques.
Right.
First, there's uterine artery embolization, or UAE. This is a procedure where an interventional radiologist threads a catheter into the blood vessels feeding the uterus and injects tiny particles to literally block the blood flow.
So it physically starves the diseased vascular tissue, causing it to shrink.
Exactly. It cuts off the supply lines.
And it works pretty well, right?
Yeah.
The clinical series shows a 70 to 90% symptom improvement.
It does work well, but it carries a nearly 30% recurrence rate.
Oh, wow. Why so high?
Because the uterus has a very rich collateral blood supply, so the disease often finds a new way to vascularize and just returns over time.
Ah, I see. Then there's thermal ablation.
Yeah.
So we have radiofrequency ablation, percutaneous microwave ablation, and my absolute favorite piece of tech from the reading, high-intensity focused ultrasound, or HIFU.
HIFU is truly remarkable. It is entirely non-invasive.
Right. They literally shoot sound waves from outside the body, passing harmlessly through the skin and healthy tissue.
Yeah.
But they calculate exactly where those waves will intersect deep inside the uterine muscle.
Yes.
It's like using a magnifying glass to focus sunlight on a leaf. At that exact point of intersection, it generates intense heat, inducing coagulative necrosis. They're literally cooking and killing the diseased tissue without making a single surgical cut.
It's brilliant physics, it really is. And on the purely surgical side, for those needing physical removal without losing the organ, there's adenomyometry.
Which is cutting it out.
Yes, that is literally cutting the diseased tissue out of the uterine muscle with a scalpel.
Mhm.
But unlike fibroids, which have a hard capsule and can be popped out cleanly like a marble from jelly.
Adenomyosis blends right into the healthy muscle.
Yeah.
There's no clear border.
Exactly. Because it's weeds in the brickwork, it's incredibly difficult. Surgeons often have to use complex triple flap closures, essentially folding and suturing the remaining healthy muscle over itself multiple times just to reconstruct a functional uterus.
That sounds intense.
It is a major surgery, though it does drop the recurrence rate down significantly to about 12.6%.
But wait, if the disease is diffuse, meaning the weeds are spread everywhere evenly throughout the entire house, not just in one single clump, how do you zap the bad tissue with microwaves or HIFU without completely destroying the healthy muscle?
And that is the ultimate limitation of these ablative procedures. Interventional radiologists have to be incredibly strict with patient selection.
Okay, so it doesn't work for everyone.
Not at all. If the disease is focal, meaning one localized clump of adenomyosis, you can target it safely. But for diffuse disease, the success rates of heat ablation drop significantly.
Because you'd have to shoot up too much of the organ.
Right. Trying to zap diffuse disease damages far too much healthy tissue, doesn't provide enough relief, and unfortunately, the long-term data shows many of those patients eventually require a full hysterectomy anyway.
Which brings us to the ultimate tension point in this entire deep dive, especially for the younger listeners who are now finally getting correctly diagnosed in their 20s and 30s. How do these aggressive treatments impact a patient's ability to actually carry a child?
It is an incredibly delicate and honestly heartbreaking situation for many patients. First, the adenomyosis itself inherently impairs fertility.
Just by existing.
Yes,
Yeah.
that massive inflammatory environment alters sperm transport, it significantly lowers IVF implantation rates, and it drastically increases the risk of early pregnancy loss. We're looking at data showing up to 25% of women undergoing assisted reproduction have this condition.
And the awful catch-22 is that the medical treatments we talked about, the progestins and the GnRH antagonists, they act as contraceptives. You literally cannot try to get pregnant while you're on them.
That's right.
And the interventional procedures aren't simple either. Endometrial ablation, which burns away the inner lining to stop the bleeding, is a hard contraindication for future childbearing. The lining just can't support a placenta after that.
No, it can't.
And that complex surgical adenomyometry, taking a scalpel to the muscle, carries a really terrifying risk of the uterus actually rupturing during a future pregnancy, like a risk of up to 6%.
It seems incredibly bleak, I know, but the clinical data shows that overall pregnancy rates after fertility-sparing interventions like a meticulously done adenomyometry or targeted thermal ablation for focal disease actually hover around 50%.
Really?
Yes. So a healthy pregnancy is absolutely still possible.
So what does this all mean? If you are a patient navigating this, you are caught between a rock and a hard place. You either treat the unbearable pain and risk damaging your uterus permanently with heat or scalpels, or you suffer through the massive inflammation to try and have a baby in an incredibly hostile, inflamed uterine environment. How does anyone make that choice?
This raises an important question about the nuance of personalized timed care. It isn't always about permanently removing the disease. Sometimes it's about strategic timing.
Like threading a needle.
Exactly. For a patient trying to conceive, reproductive endocrinologists will often use short-term suppressive therapies. For instance, putting a patient on a GnRH agonist for just 2 months right before an IVF cycle.
Oh, to induce that temporary menopause.
Yes. It acts like a medical fire blanket. It temporarily shuts down the hormones to quiet the inflammatory environment, shrinking the boggy tissue just long enough for an embryo to safely implant.
Wow.
And once the pregnancy takes hold, the hormonal environment shifts naturally. It's about opening a brief window of opportunity before the inflammation flares up again.
A temporary fire blanket to give life a chance to take root. That is incredible. We've covered so much ground today, We started with a deeply misunderstood disease that historically was only ever found in the pathology lab after a doctor removed the entire uterus.
And we've watched the science evolve into a landscape where this condition can be precisely mapped with 3D MUSA ultrasounds.
Right. Starved of blood supply and treated with intersecting ultrasound waves and specialized hormones.
The paradigm of how we view, validate, and treat chronic pelvic pain has fundamentally shifted. We are finally moving away from the dark ages of normalization.
We really are. And the biggest takeaway for you listening, advocate. If you or someone you love is complaining of severe pelvic pain or incredibly heavy bleeding, do not let it be brushed off as normal cramps.
Never.
Ask about adenomyosis. Ask for a 3D transvaginal ultrasound. Ask about the MUSA criteria.
And I'll leave you with this final thought to ponder. We briefly mentioned those investigational drugs earlier, specifically valproic acid.
The anti-seizure med.
Right. It's currently used for seizures, but researchers are studying it for adenomyosis because it targets the condition's epigenetics. Epigenetics is the study of how behaviors and environment can cause changes that affect the way your genes work.
Okay.
It doesn't change your DNA sequence, but it changes how your cells read that sequence, essentially their cellular memory.
Oh.
If an anti-seizure drug can show early promise by reprogramming the epigenetics of these invading cells, could the ultimate cure for this devastating physical disease lie entirely within the realm of hacking our cellular memory, rather than relying on borrowed hormones or scalpels?
That is a wild thought. Curing structural physical pain by hacking the cell's memory to forget it's supposed to be a weed in the first place. Thank you for joining us on this deep dive. Keep questioning the world, keep advocating for yourselves, and keep exploring the hidden science all around you. Until next time, remember, even when the diagnostic picture seems murky, the truth is finally coming into focus.